Thank you to the organizing committee of the 7th Annual Peking University Gynecology Oncology Summit Forum 2022, especially Professor Wang Jianliu and my friend Dr. Song Jianming and the ISGE that have already invited me to talk at these prestigious events. I'm Eddie Hartono from Department of Obstetrics and Gynecology, Faculty of Medicine, University of Hasanuddin, Dr. Wahidin Sudirohusodo Hospital, Makassar, Indonesia. And now, my position is President-elect of ISGE, International Society for Gynecology Endoscopy. My talk is about hysteroscopy, see and treat in your private office. As we know, the gold standard for endoscopic evaluations of uterine cavity is hysteroscopy. Why hysteroscopy? Because hysteroscopy allows visualizations of endocervix, endometrial cavity, and tubal ostia. Hysteroscopy may be performed in an office setting or in the operating room. Many of us now move from the operating theater, OT, to the office hysteroscopy. Office hysteroscopy allows cost-effective, safe, reliable, very accurate in diagnosis, easy to perform even for less skilled operator, allow sampling for histopathology, minimal invasive diagnostic and surgical tool, very rapid recovery and low morbidity, enhance physician productivity and improve patient satisfaction, enables patient to resume normal activities immediately post-procedure when NSAID alone are used. Patients appreciate the convenience of the Z and treat approach to a gynecology problem and often prefer avoiding the inconvenience of going to the OR and added risk of undergoing anesthesia. This is the normal hysteroscopy. As we know here, this is the external ostia, and this is the canalis cervicalis. This one is internal ostia. This is the uterine cavity, left and right ostium tubal, internum. What can be seen and treated, like endometrium sampling in hyperplasia or in uterine cancer, or endometrial polypectomy, lysis of intrauterine synechia, removal of small submucous leiomyome, removal of RPOC or retained product of the conceptions, hysteroscopic metroplasty or septoplasty. Yeah. Tubal sterilizations, like here is Asia, retrieval of dislodged IUD or corpus alienum. This is the Asherman syndrome, as we can see here, the adhesions between the uterine cavity, and then we lysis it by cutting the adhesion there with TCRM, transcervical resections of the myoma, especially so for submucous myome, we can resect it. We can also polypectomy for polyp cases, endometrial polyps. Okay, we can just cut the pedicle here. Okay, this one is the uterine cavity, the left and right of the ostia, tubal ostia there, and this is the pedicle. Here, this one. So we can cut it at the pedicle easily, as you can see here. This is the pedicle. Okay, we can just cut it. It's so easy. We can perform it in our private office with the office setting. Or we can see the tubal patency for infertility cases. This is the cervix. External ostia. We come to the cervical canal. And then the internal ostia of the cervix. And then we come to the uterine cavity. This is the left of the tubal ostia, and that one is the right side of the tubal ostia. We can make bubble there with the syringe. Also, we can do the tubal occlusions, like I have mentioned before. This is the cervical canal and go through. This is the internal ostium of the cervix. And then we come to the uterine cavity. Slowly, slowly, because this is the office setting, we can talk to the patients what we see, what will we do for this. That you can see this one. This is the left ostia, and we can coagulate there. It is for the contraceptions, for occlusions of the tubal, or also for the hydrosalping, so we can occlude the tubal in order the fluid of the hydrosalping cannot come into the uterine cavity. That can be toxic for the embryo. It's more convenient that we have to some pharyngectomy by laparoscopy or laparotomy. We can also in the office setting without anesthesia for this. Yeah, we can coagulate there with the bipolar roll ball here, the ball there. We occlude the ostia in the left side and the right side there. You can see the one is this, the fluid from, this is from the hydrosalping patients. So we occlude the tubal in order to like salpingectomy. We occlude that ostium so the fluid cannot come into the uterine cavity. Okay, patient selections for office hysteroscopy. Patient selection is crucial for successful office hysteroscopy. Patients has to fully understand the procedure and be positively motivated to undertake it, and know indications and the contraindications for the patients. Approach to a successful patient hysteroscopy. First, patient counseling and selection, procedure selection and approach, minimizing cervical dilatations, because it's a very crucial point, because cervical dilatation sometimes make it very painful. Timing and endometrial preparations, analgesia. Okay, patient counseling and selection. Exclude patients with cervical stenosis, limited mobility that impedes positioning, comorbidities that require intensive monitoring, or who cannot tolerate the procedure with a local anesthetic. Provide anticipatory guidance about the degree and durations of discomfort. Verbally reassure the patients during the procedure. And procedure selection approach. Choose procedures that are brief, not more than 30 minutes. Some operators said maybe as long as the patient's comfort, or immediately stop the procedure if the patients feel uncomfortable or painful. Perform diagnostic or minor operative procedure. Minimize intraoperative pain. Minimizing cervical dilatations. Adequate cervical dilatations, important step in hysteroscopy. Nearly 50% complications are associated with difficult passage of the hysteroscope. Pre-treat with prostaglandin the night before the procedure. For example, a single dose of misoprostol per vaginal. Use a narrow caliber hysteroscope, less than 4 mm. Timing and endometrial preparations. For premenopausal women with regular menstrual cycles, the proliferative phase is best for visualizations of the uterine cavity. In reproductive age women with irregular uterine bleeding, the ideal time for the procedure is unpredictable. Thinning agents should be used only when the surgeon plans operative hysteroscopic resections of a leiomyoma or endometrial ablations. Thinning agents should not be used when diagnostic hysteroscopy alone is planned, as these hormones may influence the histology of the endometrium. Analgesia. Choose an anesthetic plan specific to the patient and procedure. For example, procedure that include endometrial biopsy or use a larger diameter hysteroscope are more likely to require analgesia. Not using anesthesia appears particularly appropriate for diagnostic procedures using a hysteroscope that is less than 4 mm in diameter. Difficulties and contraindications. First is cervical stenosis, cervical lacerations, uterine perforations, embolism, vasovagal attacks, pain, bleeding, or infections. What about the cost? It's beneficial to the patients and also for the physicians. As we know, physicians' payment in 2016, 2017 is only 250 to 271, but the facility payment about 1,800 to 2,000 US dollar, and with ambulatory surgical center it's quite the same, but in office the patients pay less. You can see here, the patient only pay for about 400 or 500, no facility payment. You can see there, it's very beneficial to the patients and the physicians as well. So in this, all the fee can go to the physicians and not the facility payment here. Pathway to hysteroscopy. Patients attend GP, general practitioner, with an abnormal uterine bleeding, take the history, examination, investigations, and then managed by the GP. Patients can be treated, reassured, and discharged. If not, patients referral to the gynecology. In this department, history examination, investigation, swab, smear, bloods, PIPEL, endometrial biopsy, TVRS, USS, transvaginal ultrasonography, and then managed in GOPD, general outpatient department, referred on or back to the GP, and patients treated, reassured, and discharged. If endometrial pathology cannot be excluded or suspected at GOPD appointment, endometrium cannot be clearly seen on transvaginal ultrasonography, endometrium looks abnormal on transvaginal, PIPEL biopsy is needed or inadequate, polyps, fibroid, septum seen on transvaginal ultrasonography, patients request sterilizations or endometrial ablations or for fertility assessment, then the patients referred for diagnostic or operative hysteroscopy with the endometrial cavity visualized, endometrial biopsy taken, or operative techniques like sterilization, polypectomy, fibroid resection, and adhesiolysis. Okay, thank you all participants. As these occasions, I will invite you all to our annual ISG International meeting in conjunction with our 10th National Congress of Indonesian Gynecology Endoscopy in Bali. I invite you all to come to Bali, our island of God. Please save the date. Pre-Congress May 24, Main Congress 25 May to 27 2023. We all invite you in our country, our lovely country, Bali. See you all in Bali. This is International Society of Gynecology Endoscopy, and in conjunction with our Indonesian Gynecological Endoscopy Society. Okay, we are ready to welcome you all in Indonesia. Thank you very much.